end of the presentation. Thank you.
Thank you, Fred. Good afternoon, everybody. I'm so happy to be here this afternoon or this evening, or probably this morning for some of us, just to engage you in a short conversation on lot-to-lot verification. I'm so happy to be here. This is my first time facilitating. I have listened to many speakers from here. I have attended several sessions, some very technical, others a bit soft. And LMSK is such a great platform where everybody is able to learn from one another. And I want to appreciate you, Fred, and all the team at LMSK who have invited me to share just a few things that I know concerning lot-to-lot verification. I want to believe that our participants are enjoying the Eid al-Fitr holiday. For some of us who are still at work, join us for just a few minutes. For those of us who are still probably getting something to eat in this holiday, we wish you all the best. And we pray that at the end of this holy month, the prayers that you have been having will finally be answered. So we want to wish all our brothers and sisters who profess the Muslim faith a happy Eid al-Fitr. So going back to our topic of the day, and I just want to share not everything about lot because it can be quite wide. Allow me for the time that is there, probably 30 minutes or so, to talk about an introduction to what it is all about, some of the requirements when it comes to lot verification, and you'll also allow me to share an approach, a workable approach or approaches for lot verification that we can use particularly for quantitative tests. So for today, allow me to just dwell on quantitative tests because for qualitative, there's nothing so much to worry because we're just talking about the degree of agreement between the older lot and this new lot. But for the better part of this conversation, I'll be talking more concerning quantitative tests, and then I will then let you to ask any questions that you may have on this area or other related areas. So walk with me. For those who are using their phones, feel free to turn it on the landscape mode so that you can be able to follow through some of the slides and keep noting down your questions. I hope I'll be able to answer a good number of them. Some of you, you're able to ask very complicated questions. We will try what we can. And what we may not be able to answer in this session, we can probably create another platform, another time. Otherwise, thank you so much for joining us, even in this busy day. Now, as we go on with our businesses as laboratory professionals, the consumers of whatever we do, either clinicians, they could be physicians, they could be patients themselves, and they always trust that whatever results we are going to release to them, they are reliable and they are credible enough to be used for decision making. But what they may not know on the other side is that there are so many factors that can impair the reliability of the test results that we are all the time churning out for them to make decisions in terms of managing or monitoring the condition of their patients. And among the many factors that can affect the reliability of the test results that we give out is lot-to-lot variation. Many times we have talked about other issues, equipment capacity, the personnel competency, the environmental conditions, the infrastructure. We have talked about many things in different sessions. We have even talked about, our ability to do those tests. But for today, I just want to focus on one of those factors that can really hinder the reliability of the test results, and that is lot-to-lot variation. Because these reagents that we use for testing, they are manufactured in different seasons, in different batches. A manufacturer is not able to really, manufacture reagents for a lifetime. So they will keep manufacturing these testing reagents from time to time. And therefore, they are going to use different materials. They are going to use different compositions, different procedures, different equipment. And even the manufacturing can also be done by different personnel as well. And therefore, from one lot of a reagent to the next, you expect some variation, some degree of variation. And this is what we want to talk about today, because this is what can hinder the consistency in terms of our testing. And remember, when we talk about quality, when we want to ensure that we deliver quality to our patients, one of the domains of that quality is consistency. That if a patient visits our laboratory today and we do a testing, and then probably come a month later when you're having a different reagent, a different personnel, a different everything, they should not notice variation in terms of how we do the testing or even in terms of the results that we give to them, unless they have a condition, they have a medical condition that then would cause that kind of a variation. Otherwise, in terms of what we do, we should ensure that all our processes, all our procedures, all our way of doing things are able to deliver consistency across the testing phase for our client. Now, like we have said, one of the threats to that consistency is lot-to-lot variation, which comes from differences in the reagents that we are using. So lot-to-lot verification is that process of comparing a new reagent or maybe a new control or a new calibrator lot with the old to confirm if there is equivalence in terms of performance before we subject this reagent to patient testing. That with the understanding that some of these reagents that we're using now, or that has just been delivered to the laboratory now, may not be exactly the same as what we have been using all along. We want to make sure that once we receive these reagents, we are going to confirm it is performing its testing just like the old reagent that we have been using. So that is what we'll be talking about for the better part of this session. Now, why is it important to do lot-to-lot verification? First, we want to confirm the manufacturer's validation claims. Now, remember, every time a manufacturer comes up with a new batch or a new lot of a reagent, in the factory, they're going to confirm that that new reagent is performing just like the previous one. That they will do before they churn it out to us for usage. Just like in any other industry, before they bring out that reagent, they will truly confirm. They will confirm that the reagent they have manufactured is the same as what they had manufactured earlier. And so they'll put, some claims telling us, the verification, the validation report is saying that the reagent has not changed in terms of accuracy. There's no change in terms of precision. There's no change in terms of linearity. The reagent is still able to perform just like the other one. So when we subject our kit to a lot-to-lot verification, then we are, number one, confirming that what the manufacturer is saying is actually true. Now, number two, we want to detect if there are any systematic shifts or maybe biases or trends between the new reagent lot number and the previous lot number. We want to detect if there are any flaws in terms of transportation and even the storage systems of our distributors. And we also want to maintain continuity of patient monitoring. So if we have this patient who has been undertaking this drug and they have been faithful in adhering to the clinician's instruction of taking that drug, then our reagent that you use to test should be able to be consistent. You should be able to provide consistent results with, what the patient is doing on the other side. Now, this verification also ensures traceability and comparability of results over time. And it's also a crucial requirement to ensure compliance with all the accreditation standards like ISO 15189. Good. So let me take you through some of the requirements of a lot verification so that probably we can be able to get it from there. And you know that our Bible, the document that guides the global best practices has mentioned the issues of lot verification in about two clauses. And maybe that is what we can talk about now in brief. And then I will introduce you finally to some of the approaches that we can use. When you go to ISO 15189, clause 6.6.3, the standard introduces us to reagent and consumables acceptance testing by telling us that each reagent or each new formulation of examination kits with changes in reagents or procedure, or a new lot or shipment shall be verified for performance before placing it into use, or probably before releasing the results to the clinician or whatever is appropriate. Now, of course, that should be done also for consumables, confirming that the consumables we are using, whether it is the media, the culture media, whether it is the EDTA containers and all those vacuitainers, we want to confirm that they are verified to ensure suitable performance before we start using them for patient testing. Now, under the note, the standard, besides just telling us to do verification of new lot of reagents, it goes ahead to tell us some of the approaches. And many times we usually ignore some of these approaches because they're in the notes, because in any case, no one will ask you to, to implement something that is there on the note. But you'll discover some of these notes contain very crucial information that will then help us to implement the standard appropriately as desired by the drafters of the document. So note 1 indicates that comparative IQC performance of new reagent lots and that of previous lots can be used as evidence for acceptance. So that means even if we not be able to have any other measure, for as long as we are doing IQC, we can use those IQC results to confirm if the new reagent lot and that old reagent lot are performing in a way that can ensure reliability of results. But then still under that note, the standard continues to tell us that patient samples are preferred when comparing different reagent lots to avoid issues with commutability of IQC materials. That is to tell us that it's a preference of this standard that we use patient samples to compare how this new reagent lot and the previous one are performing, especially where there is commutability of IQC materials. When you hear of commutability, this is just an indication of, this IQC material cannot be used across different platforms. That's the indication of commutability of IQC materials. Then note 2, verification can sometimes be based on the certificate of analysis of the reagent. That means we can look at the data that the manufacturer has given us in terms of whatever they did with the reagent. They confirmed this precision, they confirmed its accuracy and all that. And we will try to have a similar experiment once the reagent arrives in the lab, just to see whether the reagent is comparable in terms of performance between the current one and the previous one. Now, this note two, usually, we use it, especially when it's our, a reagent has not been used for a longer period. And so it's like we are repeating the initial verification that we do when we have a new reagent or a new equipment installed in our facility. Now, when you go further to 7.3.7.2 and IQC, the standard requires that you have a procedure for IQC. And among the many things that that procedure should contain is number two, that the procedure for IQC should allow for the detection of either lot-to-lot reagent or calibrator variation. That means that as we undertaking our internal quality control, as we run our QCs like we do every other time, now this procedure should also be able to help us when we have a lot-to-lot reagent variation, then our QC should be used, to help us in that area. Now, to enable this, the laboratory procedure should avoid lot change in IQC material on the same day or on the same run as the lot-to-lot reagent or calibrator change or both. Now, that statement sometimes sounds confusing, but what the standard is indicating is that, we have three things here: the reagent, the calibrator, and the QC. Now, we should not attempt to do a change of the three at the same time. Because if you try to change the reagent lot, the QC lot, and the calibrator lot at the same time or the same day, you'll not be able to tell which one exactly causes a variation. Is it the reagent? Is it the calibrator? Is it the QC? So the standard is indirectly advising us to do changes of the reagent, QCs, and calibrators at different times so that we can be able to detect, what issues are happening with our testing system. It's just like, what people tell the government: don't change everything at the same time. Don't change the health systems, the education systems at the same time, because sometimes changing everything at the same time, people will start complaining and you not be able to tell exactly what is the issue. Is it the education system? Is it the health systems? What is it? Is it the road construction issues? What is it that is causing a problem? So just like that, for testing, we should ensure that our SOP then gives us a provision to ensure we change one thing at a time, so that then we can use the other to do confirmation of the changes that we did on the other. What I mean is, if we change a reagent lot today and we haven't changed the IQC lot, it means we can use the IQC to confirm if there is any variation between the old and the new reagents. Otherwise, if we change everything at the same time, of course, some tests methods will, come with a reagent and the QC, and so you have to change everything at the same time. It means then you have to use a different approach to confirm the reagent lot variation. Very good. So that is it in terms of what the standard requires that we do. Now, allow me just to highlight two practical approaches for this, and I will not take long so that we can be able to answer to a few questions. Now, and I just want to use the approaches given by the standard. That is a comparison of internal quality control results. And number two, the other approach is comparison of patient samples results. Now, on the first one, when we say comparison of IQC results, this involves evaluation of IQC performance of the old and the new reagents. That means we want to check how the new reagent is performing in terms of IQC in comparison to the old reagent. That can be one of the ways of doing lot-lot verification. And by the way, before we even get into these technical details, remember when the reagents were received earlier, you went ahead and you did the physical inspection of the reagents just to confirm the expiry dates. You wanted to confirm whether they are leaking. You wanted to confirm whether there are any issues physically with the reagents. That was the initial verification, actually. But now, in terms of performance, is now what we are talking about checking any of these two approaches: comparison of IQC results or comparison of patient samples. And I have chosen the first one, as indicated on the standard, a comparison of IQC results. Now, how do you do this? Now, number one, you begin with a calibration, and most of you will agree with me that anytime a new reagent lot is loaded on that analyzer, the manufacturers always ask us to perform a calibration, on the new reagent, because you don't know what the manufacturer changed. You don't know what the manufacturer did with the new reagent that is different from what he had done on the old reagent. So you do a calibration, and as always, we have to confirm whether the calibration is done well using a QC. And so you go ahead and perform a quality control, running known samples on that analyzer. Now, if the results are not successful or if they have failed, you will troubleshoot, using your own the usual corrective measures that you have for your IQC procedure. And the QC materials being analyzed on this new reagent lot must be of the same lot as those previously analyzed on the old reagent. Now, for us to proceed with comparing, because you can't compare a new IQC lot with a previous one. It has to be the same. So once you have done your calibration, it has passed. If you want to use this approach of comparing IQC results, then the IQC material you'll be using must be the same lot as the previous one. Remember, we have seen in the standard that we should not change, the two of them together, reagent and the QC together. So once you have analyzed your QC results on these QC samples on this new reagent, you will go ahead and perform a comparison. So plot your results from the new and the old reagents on a particular form. You may have this form and call it, lot verification form, and then calculate the average bias. So what we mean here, maybe I can try to illustrate. I don't know whether I have that capability here. Um, I think, okay, maybe I don't have the rights. I don't know. Maybe Fred, you can guide me. Do I have the rights to write on this on the screen?
Yeah, you should. You should have.
I should be having. Maybe you can guide me. Where do we go? Okay. Seems I'm forgetting. I'm forgetting how exactly to edit to outright on the screen. But let me just try to talk about it. So we are saying for this first approach, Fred, if you manage, you can probably guide me, but I'll be trying to explain. So if you have three levels of IQC, if you have three levels of IQC. Bernard is trying to advise me. Okay, okay. It's not what I wanted, Bernard. Maybe you can. Thank you so much. Now, if you have three levels of IQC, and these IQCs had previously been run on the old reagent, you're going to pick the results that were got from that old reagent. So you have this, you can see the second column where you have a space for indicating the results for level 1 of IQC that you had gotten with the old reagent. You have a space, a similar space for level 2 and a similar space for level 3. And then this same QC sample is analyzed on the new reagent lot. And so you're going to pick your results now on the new reagent lot and have them plotted on that column. So IQC results for level 1, IQC results for level 2, IQC results for level 3. You have them there. Now, it is likely that all these results were passing. You know, your IQC results were passing based on the ranges that you usually use or the ones given by the manufacturer, or whether you're going to use your own acid results. All the results are passing based on the ranges, but you still want to compare if my performance of IQC is relating or is correlating with what I was getting the other time, because I could be passing now, but probably I'm just passing by fluke. It's just by God's grace that my QC results are passing. And so, even though we are going to consider, that as an IQC that has passed, we want to confirm whether the new results are performing just like the new results with the new reagent lot are performing just like the previous one. So we are going to plot that. So let's assume level 1 was giving us 10 with the old reagent, while level 2 is giving us 15. So not level 2, but with the new reagent, the same level is giving you 15. So we are going to calculate our percentage bias. And how we will calculate our percentage bias, I was hoping to illustrate, you take your new result, you subtract the old result. Whatever you get, you divide by the old result, because we are assuming that the old results are what is desirable. Then whatever you get, you multiply by 100%. That is calculation of percentage bias. You do that for level 1, for level 2, and for level 3. Because what we want to check is to confirm whether our new reagent lot is giving us results which are comparable across all the available concentrations that we have for IQC. And then we'll go ahead and do our average bias just by taking, uh, all the biases we've gotten for level 1, level 2, and level 3, do the total of that, divide by 100%, divide by 3. Now, if your percentage bias was negative, at this point, we will ignore our negative sign, because the negative sign in this case is just to tell us the direction of, where our values are in comparison to where the previous results were. Is it on the lower side or on the higher side? And then once we have calculated our average bias, we will go ahead and compare that average bias with total allowable error. That is how we do comparison of whatever we have determined in our experiment in terms of average bias and the total allowable error. So how do you interpret, or how do you know if your reagent is comparable or not? And I'm saying I just went straight ahead to the real practice, so that I don't have to explain a lot of theories on this lot verification subject. Now, if your average bias, and this is just basic statistics, if your average bias is less than or equal to the total allowable error, it means that the difference in the IQC performance on the old and the new reagent lots is not clinically significant. There's a difference, yes, because probably you got it as 10 initially with the old reagent. With the new reagent, you get it as 15. and you go ahead to calculate the percentage bias for both level 1, level 2, and level 3. Now, if that difference will not exceed the provided total allowable error for that particular parameter, then we are going to say that there is no clinically significant difference between the performance of our new reagent and the previous one. And so the new reagent is therefore reliable just like the other one. It means there is nothing to fear about. It means that our calibration passed, our AQC passed, and when we do the percentage bias between our performance with the new, between the new and the old reagent, we can confirm that our reagent is as reliable just like the previous reagent that we are using earlier. Now, if this average percentage bias is greater than the total allowable error, it means that the difference in the IQC performance between our two reagent lots are clinically significant. It means that then our new reagent is not as reliable as the previous one because the values we are getting with this new reagent and those that we are getting with the old reagent, they have a difference. And looking at their percentage deviation between the two values, they are way off what is allowable. They're way off the total allowable error. That is the first approach for comparing IQC results. Now, allow me to just highlight some of the advantages of this approach and the disadvantages. Now, first is in terms of the advantages of just comparing the IQC results, you have ready data because initially you had already run this IQC with the old reagent. And just like our usual practice, anytime we have a new reagent lot number, we will do calibration and then IQC. And that means you don't have to run anything else. You just use those IQC results as they are and subject them to that comparison. So you have the data available, readily available. Number two is that this approach is, I would say it's cost effective because then you don't have to rerun, the patient samples. This approach does not require you to run patient samples. You are quickly comparing the IQC results and just checking them against the total allowable error. So it provides a rapid assessment that you are able to do this assessment immediately because for most of us, we don't even run patient samples up until we have run the IQC. And so with that quick comparison, then you're able to, proceed with patients testing once you confirm that the differences between your two results are not clinically significant. And then finally, it helps us to detect systemic shifts and trends because these results are already there on the LGI chart. The results for IQC of the new reagent lot and those of the previous reagent lot, they are all plotted on the LJ chart or any other statistical technique that you're using to plot our QC results. And therefore, we can always tell whether there's a shift, in terms of results from the lower side of the mean to the upper side of the mean, or whether there are any biases in the performance of that equipment. But now, it also has some disadvantages because number one, it may have an issue with the matrix. Now remember, some of the materials we use for IQC are not necessarily the same with patient samples when it comes to composition of that material, composition of the proteins, composition of the, the analytes and all that. And therefore that matrix effect difference can always lie to us because you see the QC is a refined material only containing the analytes that are supposed to be tested on that particular sample. But you see, a patient sample has all these other confusing materials, which then makes the challenge of our analyze, which then complicates this challenge of checking how good our equipment is performing. The number two The results we get using this kind of comparison may not always be representative on the patient samples, not always, because like I'm saying, some of these QC materials we're using are so refined. They don't have any that, they don't have any confusing substances, and therefore they can always mislead us when you're doing comparison of results. And then there's a risk of false acceptance due to all that. So that is what we can say about the approach, the first approach of comparison of IQC results between the new and the old reagent lot. Now let me now go to the other one, which probably most of us, I think we attempt to use this other approach. And this is a comparison of patient samples results. So this involves evaluation of patient samples on the new and the old reagent. And what happens is that we will not only rely on the IQC results that you've gotten after doing the calibration. We will go ahead and subject our analyzer to some patient samples that were previously run with the old reagent lot number. So the first thing here is that after installing a new reagent, definitely we'll do a calibration. And for most of the analyzers, if it's the same lot number, you're not required to do a calibration. But if it's a different lot number, most of the equipment providers, most of the reagent providers will always remind us to make sure that we do a calibration just to realign our equipment, our new reagent with the equipment again. So once the calibration is done, we will go ahead and do the QC. And if the QC results are passing, then we'll proceed with the other a bit. If they are not passing, then we have to troubleshoot and confirm that they are passing before we proceed with any other activity. Now, in this case, the QC materials being analyzed on this new reagent lot do not have to be of the same lot, because in any case, we will not be comparing the IQC results. We will have another step after this number two. Remember, for the other approach, we mentioned that the QC materials you are running then must be of the same lot number as the previous one, because you're going to do comparison of the IQC results in that approach. But in this approach, because we are not comparing the IQC results, we don't require that you have the same lot number of the IQC like the one you had used with the old reagent. And so after that, you will go ahead and do a third thing, which is analyzing and comparing patient samples. So you're going to take at least 3 samples, which were previously run with the old reagent, and rerun them with this new reagent. Then you go ahead and plot them on whichever form that you're using. I'm still not able to write down, but I believe you have gotten the concept. That if you take sample 1, you're going to retrieve its results with the old reagent, and then try rerunning that sample now with the new reagent lot number. So if earlier you had gotten a creatinine of 90 with the old reagent, you're going to rerun that sample with the new reagent to see how much of creatinine you're going to get. If you get 100, you're going to plot it on that column, the one for results with the new reagent. And then you go ahead and calculate the percentage bias. Now, the percentage bias, for anyone who may be joining us now, we've just mentioned that for percentage bias, you're going to take your new lot values, your new reagent lot results. You subtract the old reagent lot results. Then whatever you get, you divide by 100 by the old reagent. Then you multiply by 100%. So, for instance, if your new reagent lot values is 100 micromoles per liter, and the old reagent lot values was 90, then you're going to take your 100 minus 90. then I'm sure you're going to get 10. Now divide that 10 by the old reagent lot, which is going to be 90. Then you multiply by 100%. That is what you are calling the percentage bias between the new reagent lot and the old reagent lot. So you're going to do that now for another sample and maybe two other samples. And the reason for these two other samples is just to make sure that you capture all the possible samples that you can get in your lab. If you're talking about HB, get a sample with a low HB, get another one with somewhere a HB within the normal reference ranges, and then another one that is out of range on the higher side. And let's see what kind of percentage biases you are going to get for each. Now, because our interest is just to see generally how our equipment, how our new reagent is performing, we will do an average of those three results. And just to repeat myself again, even if you had one of the percentage biases as with a negative sign, at this point you will ignore the negative sign because our interest is not really the negative sign. It is just to know how far our new reagent results vary from the last one, from the old reagent lot number. So you're going to take your three results and do a total of them, then divide by 3. Then later on, we will compare our average percentage bias with total allowable error. And like I mentioned earlier, every parameter has its own established total allowable error. And this total allowable error usually incorporates the known biological variation for this parameter against and also other possible factors that can cause variation of results. So, how do you know if your new reagent is okay or not? Just like we said for the other one, you are going to take your average bias and compare it with total allowable error. Now, if the average bias is less than or equal to total allowable error, it means then that the difference in performance, not IQC, but in the patient sample's performance, is not clinically significant, and therefore the new reagent is considered as reliable as the old one. That's what it means. Now, if the opposite happens, that's whereby you find the average bias values is higher than total allowable error. It means that the difference in IQC performance, not in the IQC, but in the patient test performance, is clinically significant. And therefore, the new reagent cannot be considered as reliable as the previous one because there is a considerable difference between the values you are getting now and what you are getting earlier. Now, some of the advantages of this approach is that number one, it's the gold standard when it comes to lot verification. If you look at CLSI standards, this is the approach they prefer, especially where it is already recognized that a particular IQC or a particular assay shows commutability issues across reagents. Now, it covers the biological variability because you are now working with a real patient sample, not a replica of a patient sample. And it's also good when a QC lot changes together with the reagents. Like some of you will agree with me, some of the tests, like immunoassays, you'll find every reagent will come with calibrator, will come with its QC as well. And so this method then will be so appropriate when a QC changes together with the reagent, because in this case, you're not comparing the IQC performance. You will compare the reagent's performance based on the performance with patient samples directly. Then number 4, it is recommended where IQC commutability issues have been observed, like where you can't be able to trust, the IQC materials that you are using, because like I mentioned, most of these QC materials are not necessarily human. They are properly refined materials, which may not have the same matrix as patient samples. But now, in terms of disadvantages, is that this approach then requires you uh, uh, to consume more reagents uh, because it means if you are changing a reagent a day, let's say for creatinine, it means you are going to do the calibration, which will probably consume, I don't know, maybe two, three tests. You do QC, which will consume probably two tests. Those are five. And then you run your patient samples, which will consume an additional three samples. So it means you are likely to have consumed eight tests in just one reagent change. And so if you look at it in that way, for all the tests that you're doing, you're going to have, three additional tests just for a lot verification. And so that additional cost is something that you can really think about. Number two, it is affected by sample instability because we are saying here, we are going to run a sample that we had previously run with the old reagent. Now, some of the rare tests, like let's say magnesium and calcium and such, which are not routinely requested in our labs, you may find that the last time you ran that test was probably 3 days ago. And you are told to retrieve that sample, run it today, 3 days later. So if there are issues with the storage, it means that you cannot be able to easily compare the performance of that sample then and what you're getting today with the new reagent. And so that issue of sample instability is another hindrance for you to reconsider whether you want to use this method or not. The number four is that this method can take a longer, it can take longer, trying to retrieve some of these previously run samples, which means then you're going to delay patient testing and other activities within the lab. So it's not like IQC whereby the QCs are in a particular place, you just go and get it and rerun. For patient samples, you may have to go, check in your rack of 100 samples, trying to locate that sample. And sometimes you may discover even whatever sample you have is not sufficient to be rerun because probably it had been used for so many other tests. And so this method, though we are saying is the gold standard, it also have its disadvantages. And so as I come to the end so that I can listen to any question that you may be having, for consistency in laboratory results, we are saying let's confirm, let's minimize and also minimize variability between testing methods. And we will do that through lot verification. But let's monitor the kits that we have received. Let's check the performance of this new kit and compare it with the previous one. And if we find out that they are okay, then we go ahead, and continue with patient testing. But then make sure we minimize the variability also by the way we store the reagents, by how regular we perform our calibration and all that. Then consider efficiency while performing lot verification. Now, like we have said, if you go with the second approach, whereby you have to run an additional three samples to verify the new reagent lot, then you may find our reagents spending so much in terms of reagents just to do lot verification. So if there's no confirmed issues of commutability of the QC, let's sometimes consider the first approach because then it ensures efficiency, which we are talking about prudent utilization of laboratory reagents. Then compare the two approaches in your lab. So you have this one where you use IQC, the other one where you use patient sample. Now, if there are known IQC commutability issues, like what we have said among the immunoassays, then proceed to use IQC performance comparison approach. And then reserve the patient samples comparison approach for tests with known IQC commutability challenges. or when a QC material changes together with its reagent, like you have said with immunoassays. So I will not want to tell you that this is the approach you need to use, but I've just given you the two options so that instead of wasting so much reagents, even where there is no confirmed commutability issues, we can proceed with our IQC and only spare the patient samples only for tests that have been confirmed to have variability in terms of IQC. And so that is it. That is where I want to bring it to a close. I don't know if there are any questions. Over to you, Fred.
Thank you, Paul. I think this is a very, very well done presentation, very elaborate, and also very important to all of us, especially in this space. And for sure, I can see a lot of reactions from our members, and also I can also see a lot of compliments from our members. Thank you for even those who have sent your reactions inbox. And there are a couple of questions, yes, and I'm thinking we can just start straight away with these comments that we can see here. So yes, Lucy Madenge says, well put. Charles Sankey, great presentation, Paul. And then Dr. Helen Ogola, the CMLC caucus chairperson, says, very informative session, Paul. And I think to all of you who have sent in your compliments, thank you, thank you. Maybe, Paul, we can start with this from Kennedy. Okay. From Kenneth Achieng. What is the danger of just running the QC with the new reagent? And if it passes, you just continue testing without calculating for the total allowable error. Maybe we can start with that.
Okay, thank you, Fred. I've seen your question, Ken. The danger of just running QC and proceeding. So what you are saying is, if you do your calibration and then later you run your QC, you might find out there's probably a shift or there's probably a bias that is being maintained. And so you want to recalculate to confirm by how far my new IQC results are varying from the previous one, so that if the variation exceeds the total allowable error, then probably you can reconsider maybe doing another calibration or troubleshooting to see what else you can do. Otherwise, if you just, the danger of just running QC and proceeding is that you might end up with a shift that then affects the patient samples because you didn't compare your new reagent with the previous one.
Thank you, Paul. Yeah, sure, that is well answered. Maybe we can go to the next one from Francis Mambili. I think why patient samples are the best ones to use for lot-to-lot comparison than QC material.
Francis, I think we already mentioned that just for commutability issues, patient samples are best because they then indicate the real case scenario when it comes to the impact of that change on the patient results. So the QC can be trusted, yes, but not for all the tests that you have in your lab.
Thank you, Paul. Duke Choya is saying, Mr. Paul, can you use EQA sample for lot-to-lot verification whose performance was unsatisfactory in your lab in the event you don't have QC material?
Yes, you can use the EQA sample, but then you don't use the values you had reported earlier to your EQA provider. Probably you can use the values, the assigned values given by the EQA provider instead of the values you had gotten in your lab.
Okay. Thank you. Hemstone minor, are there other formulas or statistics that we can use apart from the one of percentage bias? Where is the formula for percentage bias referenced from?
Okay, good. Yes, Hemstone, of course, there are other formulas. There are labs which will do about 15 to 20 samples and calculate the correlation coefficient between your new results on the new reagent and those of the previous reagent. So you can do the correlation coefficient, that's another one. So this formula of percentage bias is available now on the Westgard and also on the CLSI guideline for performance of lot verification.
Thank you. Thank you. I think this is a comment there on in regards to that from Anne Kimeu. And she says, we reference from biological data variation site. Okay, thank you, Anne. Thank you for that. So maybe Francis Mambili, in terms of values, what are the acceptable bias variations?
Francis, just like you have mentioned, we compare total allowable error. And we said every test has its own total allowable error that has already been determined and published. So we can get that on Westgard site, the clear limits, and other sites that contains biological variations across different platforms.
Sure. Thank you. So this is Kenneth Achieng. I have a new reagent lot and I think my QC vials have deteriorated. Is it advisable to use new vials of the same lot of IQC, or I just have to use the deteriorated IQC? Okay, Kenneth.
Good, thank you, Ken. So you don't use the deteriorated IQC. I believe you have new vials of the same lot. Use those. Remember here we are saying if you're doing comparison of IQC performance, make sure you're using the same lot number of the IQC, whether it's a different vial or the same one.
Thank you. There are more questions, and also if you want to maybe speak, you can always raise your hand. I will be able to unmute you, and you can always find a chance to speak. So we move to the next one from Eli Kanangila. Okay. And this is the question: is calculating average percentage bias, what is the total allowable error?
Okay, so we're saying the average bias is basically the difference between your new result and the previous one. But then because you had run more than one sample, you want to do the mean of those three values that you got so that you can compare them with total allowable error. Now, this total allowable error, this is the amount of error that is tolerable for every other test without necessarily impacting on the clinical significance of that kind of result. So maybe in another time we can have further discussion of what necessarily is the total allowable error. But basically it's that range of variations that then will not impact on the clinical significance of the test.
Okay, thank you. There's another one from, okay, maybe we can move to, okay. Silas Nusi. How would the reporting template of the lot verification for qualitative or semi-qualitative tests look like? And then maybe Paul,
Now,
I can add another one from Danson. Where do we
okay,
get the total allowable error targets? Is there a website for this chart? I think that one you have raised, but you can answer those two.
okay, thank you. So the template for qualitative tests would be simpler in that you just want to have a column for results with a new reagent, results of the new reagent, and results of the old reagent. And if the new reagent says that, if the new, let's say, H. pylori kit says that this sample is negative, it should be comparable with the previous one. Any variation, then you're going to say that the sample, the new reagent is not comparable with the previous one. So you may not have to calculate the biases. You just check the agreement that this new reagent says negative. What is the old one saying? If it says a different result from what the new reagent is saying, then you're going to indicate that that lack of agreement then shows our new reagent cannot be reliably used for patient testing. Now, where do you get these total allowable errors? I think it has already been mentioned. You can check on the Westgard site. You can check on Piecemeal. And those are some of the websites you can be able to access total allowable error.
Thank you. A lot of comments and questions here. I'm hoping we shall be able to cover quite a number. Looks like this is an area that has a lot of questions. I think let me read a few questions and then some are straight to the point. For example, Alice Maderi is saying, come up again, what is commutability? Okay, I know these are some of the terms that we understand, but maybe we have not understood well. And then the other one is also from okay, so Paul, what is commutability? And then the other one is from Monica. For audit purposes, would it raise a query when the two are used and documented interchangeably? Maybe we can take those two and then maybe just handle this one because I think it's also quite straight. Why is lot-to-lot verification important?
Okay, thank you. Thank you for the so many questions. We just try to answer what we can be able to do within the few minutes that we have. I'm trying to be direct to the points that we can be able to answer as many as possible. So why is it important? Because we have said as part of manufacturing the new reagents, we don't know how far the manufacturer has gone in terms of changing the new reagent. And so we want to confirm that this new reagent is working well, just like the previous one. What is commutability? I want to give, let me explain that by an example. If you take a QC manufactured by Sysmex, and then you try running that QC material on another platform, let's say Mindray, you're not able to exactly get the same values that you had gotten with the first platform. So we say the QC materials may not be commutable because when they are manufacturing the QC materials, they're usually manufactured for a particular platform. And if that material is going to be used on a different platform, it means they have to generate different assay values for that other equipment or that other analyzer. So when you say IQC commutability issues, we're just saying, some of these QC materials cannot be used across platforms interchangeably. Now, I think Monica asked about was it about what the assessors will say in case they find you using these two approaches interchangeably? There is no problem because, first of all, you're going to document in your procedure that the two approaches are actually acceptable in your lab. And so, based on the different scenarios, like when you don't have patient samples available, then you're going to be using IQC. When a commutability issue is already identified for IQC, then you're going to make use of patient samples which are natural in nature and which are diverse. They can be used in whichever platform. So there's no problem, Monica, for as long as you have it documented in your SOP, the different conditions when either of the approach can be used.
Thank you, thank you, thank you. I think Lucy is also giving a very good remark there. Lucy Madenge, always remember to troubleshoot If the reagent's performance disagree, sometimes this may be due to sample stability or other factors, not necessarily due to reagent performance. Okay. Thank you, Lucy. Davis Wekesa, third-party AQC materials are the best for method one to sort computability issue. Thank you, Davis. And then I'll read another comment. Okay, this is a question now, Biko Mondi. Given that it is preferable to use patient sample over IQC materials in lot-to-lot verification, is it right to use it in absolute absence of QC materials? Okay.
It is not possible to use one method entirely without considering the other one because of the different advantages and disadvantages, like we mentioned. So you may always want to use IQC just to cut on the cost, but then you discover that the IQC approach may not always be able to identify all the variations that are possible with a new reagent lot.
Very well. Let me see if there are more questions. Okay, I think there's one here from, okay, Peter Mutinda. In this scenario, do we use our standard as a calibrator? And then what are the common errors in lot verification from Catherine Mwema?
Okay.
Maybe let me read the last one. Samuel Bet,
Okay.
at what percentage buyer should we reject the new law? Thank you.
All right. Let me start with, is it Mwema? Would you repeat the first two questions, Fred?
Okay, no problem. But okay, so this is from maybe we can start from Bet. At what percentage buyer should we reject the new lot? Then we proceed to the next.
Yeah, so I think that is straightforward. The total allowable errors are already expressed in percentage. So if, let's say, a parameter like platelets, which has a total allowable error of 25%, if your average percentage bias goes beyond 25% for that particular parameter, then you are going to say that the lot verification, indicates the new reagent is not reliable. So it will depend. It will change from one parameter to the other because every parameter, every test has its own total allowable error limits.
Thank you. And then what are the common errors in lot verification from Mwema Catherine?
Okay, good. So there are so many. Some of them can arise from ourselves as a lab. Others would arise from the manufacturer or their distributors. So for the distributors, usually the issue can be the transportation issues, where they are not able to maintain the cold chain, or probably their own storage, where these materials are coming from. Probably there was an issue that was never noticed, and so temperatures went out of range, and so you can have that kind of variation. But the worst of all them all can also come from the manufacturer, where the batch they are going to give to us will not be comparable with all the other batches they have given before. And usually, when we report these, the manufacturers are able to recall a particular batch that they had already released, and it has been confirmed by different users of having such a problem. Now, the good thing with that is that many users are going to notice, and so they'll communicate. So what I can encourage is that anytime you encounter an issue with a new lot, if you confirm the problem is not on your end, make a point of communicating with the manufacturer, because the manufacturer or their distributor has then a responsibility of either replacing that reagent with for all consumers of that reagent. Of course, the other issues that can cause variation can also be on our end in terms of probably how we did the calibration. Because remember, for every new reagent lot, we are going to do a calibration. Now, if our calibration is going to be flawed, it means that the calibration curve then will cause a failure, for all the other testing that you are going to do. So it can arise from us, can arise from the manufacturer, the distributors, and so it's something that we need to really investigate where the problem is coming from.
Thank you. I think Dixon Kiagi is also adding his voice. I also think that storage of reagents matters a lot. Most lab technologists ignore this a lot. If the reagents is meant to be stored at room temperature, check and act accordingly. Same way if it's meant for refrigeration. Okay, thank you, Dixon.
Thank you, Dixon.
For
That is true. Yeah.
I think there was a final one from from Peter Mutinda, and he was saying, in this scenario, do we use our standard as calibrator?
The standard is for sure a calibrator. Because what is a calibrator? It is any material, that you're going to use to generate a standard curve. So if your standard is able to generate a curve, then for that reason it is a calibrator. I don't know whether he's asking whether we can use that standard later on to do lot verification. But it's highly discouraged. Use a standard for calibration, and then use a QC now to check if the calibration curve was derived well. So I don't know whether I've answered that, but yeah, that is how I would approach it.
Yeah, that's quite clear. So I think colleagues and team, we have it's been a very interactive session, very interactive, and maybe just to appreciate those who have taken their time. Kennedy Kanyango is saying ISO 15189 2022 is irresistible. I always yearn for more and more knowledge on the standard. Thanks, Mr. Paul. You are a good trainer. Bernard Akinyi saying, always a privilege to tap from your knowledge in QMS matters. Yeah, and everyone who has found, time to attend, we want to say thank you. And of course, I said that today we are joined with an expert, and Mr. Paul is an expert. And just in case you will want to consult privately, Paul, you can project that number. He at Rankwell Consulting will be able to assist you. So, Paul, there's a number on the screen.
Yes.
Good. So you can always reach out, and then we have noticed that there are a lot of gaps, and also this goes directly to our decision makers, lab managers. Kindly, you can see that our members are really in need of this capacity building, and maybe you can consider. So, just before I close, Dr. Helen, I'm sure you will not miss something to say. She's taking care of all of us at the counties, and I'm going to give you a minute so you can give your comments and thoughts. Kindly unmute, and then you can proceed to make your remarks.
Thank you so much, Chair of the Day, and congratulations, Paul, for informative session. One thing has stood out clearly for my colleagues that are on the we still need more sessions, especially on the ISO 15189-2022. LMSK, kindly engage more team members that are QMS experts so that they can even take us through what is new in the ISO in a brief way so that everybody can understand, because they have learned that there's more in lot-to-lot verification that I know majority of us might not be aware, especially in terms of calculating and comparing the bias and then we determine using the patient sample. It is something that might be there in the ISO, in the QMS, but majority of the MLOs are not aware. We are looking forward for empowering the MLOs, giving them that accurate information for them to deliver their services in a quality manner. This is our desire and it is our prayer that we should, all of us, be gearing towards that. So thank you so much for this, and I'm looking forward for more of your presentation. And again, with your number, I think we really need to be engaging you as a consultant so that in counties, in a small way, we can even batch ourselves to counties, the neighboring counties, so that we look for funds so that you come and empower, starting with our lab managers and the QA officers before we go to the larger community, the larger team. Otherwise, thank you so much and thank you, everybody. I was glad to join today because of the holiday. I usually look forward for some of the very interesting topics, but competing tasks make me not to join. So I was happy LSMK for actually enabling us to join today when we are having a free day. Asanteni sana and God bless.
Thank you, thank you, thank you. We can clap for our CMLC Caucus Chairperson, Dr. Helena Nogola. And thank you, Daktari, for finding time to join. And also thank you for those remarks. Indeed, it's a gap that, we just need to collectively see how we can close. Otherwise, colleagues, receive those compliments, Daktari. And Paul, we want to say that this has been very timely. And as you have heard, it says in Swahili, wengi wape. So I think there's need, and we shall, of course, organize for more sessions. And just when we reach out, kindly consider so that you can always bring these insights here. So as we come to the end of this insightful session, I think I've always said that quality in the lab is not achieved by chance. It is built through deliberate, consistent practices such as this, lot-to-lot verification. And today's discussion has reinforced this, that even those smallest variations can have significant implications. And I think before I just log out, I want to take this to Paul for his closing remarks.
Right. Thank you, Fred. I want to take this chance to once again say thank you so much for having me and for giving me a chance to share with colleagues on what I know. And it was great, engaging professionals from all across. Thank you all who shared your feedback, your questions. You tried to answer some questions also. Thank you, my boss, Lucy Mathenge from Kisumu, and also Madam Helen. Asante Daktari for the good job that you're doing back in Kisumu. I think I just want to encourage that the small things that we learn, we should be able to have a way of making them implemented in our facilities. So let's take this chance. This little information we have gained within an hour, see what you can do back in our facility, whether it is just trying to calculate those biases or just starting doing it because probably we have not been able to do it before. You now have a chance. Everything you learn at LMSK and other platforms, make good use of it because at some point we don't know whether this information will be available for all of us. Otherwise, asanteni sana. May you continue enjoying your holiday. So until another time, I want to say goodbye and thank you so much.
Thank you, Paul. And I think at this point, we just want to extend our appreciation to you for the practical insights that we can all take back and implement in our labs. And to all participants, I want to thank you for your active engagement and commitment, especially in advancing quality in lab practice. And I've said that as we continue to strive for this excellence, let us make this lot verification not just a requirement, but let it be a culture that we embed in everything that we do. Otherwise, once again, Eid Mubarak to all those celebrating Eid al-Fitr. And until next time, enjoy happy holidays and happy weekend. Thank you.